This is Cancer Buzz. I'm Summer Johnson. On this episode, clinical trial access for patients in rural areas. How one system took a passion for patient care and creativity and worked around obstacles to make sure that geography didn't stand in the way of patient access to groundbreaking treatments.
Really just thinking about how do we as a science community make sure that we are pushing that envelope. So are we looking at the appropriate eligibility criteria? One of the things that we had focused on a few years ago in our footprint was other diseases that patients may have that would knock them out of the running for being part of a clinical trial. So, maybe our population has a high incidence of diabetes and you can't go on trial if you have diabetes. How can we as a community think about choosing trials that fit our population? And if there are trials that don't fit our population, but we really should, how can we work with other key stakeholders on a more national level to make sure that the trials that are being designed really fit what's happening in the community setting? Because we know 85% of patients are treated in the community setting and not at academic medical centers.
Welcome to Cancer Buzz. Today we're looking at the realities cancer care teams face when treating patients in rural areas, specifically getting those patients access to clinical trials.
And so many patients, I think, when they consider the barriers to access here and put on top of that the additional financial barriers, and sometimes the travel makes that worse for people who are living on borderline means, many patients will make a decision that it really is not really worth pursuing treatment. For the patients who do decide to pursue treatment and are committed to that, they're compliant, they're good patients. But I think it is a factor that people weigh when they're trying to decide, is it really worth it to me to get a therapy that may extend my life, several months, given all these other barriers and how that impacts my quality of life?
That was Dr. Jack Hensoldt, medical oncologist at Bozeman Health Cancer Center and president of the Montana State Oncology Society. There are some big challenges to providing the best cancer care possible to patients in rural areas. Among them, geography and transportation, lack of specialists, and access to clinical trials. Clinical trials are no doubt crucial components of cancer care, not only for cancer research, but for the individual's cancer treatment. One health system got creative and is using telemedicine to make sure their oncology patients receive the absolute best in care, no matter where they live. Sanford Health is the largest rural healthcare provider in America. It's headquartered in Sioux Falls, South Dakota. They use a telemedicine approach for clinical trials and their unique tumor boards. We asked Lora Black, Senior Director of Clinical Research at Sanford Research, how they got started in telemedicine and how the program provides clinical trial access to patients in hard-to-reach areas.
So there was, I'll tell you just a little story. When I worked on the floor in the hospital, I took care of a lot of cancer patients, and I was just always upset about the fact that we couldn't do better, And so when I was taking care of a patient in the hospital and I had moved over to the research department, I saw this particular patient in the clinic probably about 3 months after I had started. And she came up to me and she knew I was transferring to research, and she said, "Have you found a cure yet?" So I don't like the C word, but I will say I love being part of change. Knowing that what we're doing every day is moving the bar forward for the next patient is a humbling and very rewarding experience. And Sanford has the patients at the forefront, which is really exciting.
Describe for us Sanford Health System. Paint a picture of the system and the patients that you serve.
Sanford Health is the largest rural not-for-profit healthcare system in the country. So if you think of overlaying the size of Texas, kind of square on top of South Dakota, North Dakota, Minnesota, and a little bit of Iowa, we serve patients in a 200,000 square mile area, which is mostly rural. There are some frontier areas that we serve as well, very few urban areas. So most of the population that we serve as a health system is looking at traveling a fair distance for healthcare. There may be some local clinics in their town, but definitely when you think about tertiary healthcare systems or healthcare centers, those are few and far between in this geographic area. Many of our patients are farmers, so we definitely have a fair amount of the farming community that we serve. And then the other piece to this that is more recent is the Sanford Health system merged with the Good Samaritan Society earlier this year, and that is an organization that's housed within 26 states. So our primary footprint, especially when we think about clinical research, is very much in the Dakotas and the Midwest. But Sanford does also have some institutions that think of long-term care or assisted living in 26 other states.
You work for a larger healthcare system, but I bet the challenges to providing rural care still remain. Talk about some of the obstacles that a patient could face getting access to a clinical trial in these rural settings.
Absolutely. So this has really been our passion and our mission to bring clinical trials to the patients where they are. As I mentioned, we cover a geography the size of Texas, which means patients are traveling, which on a good day maybe is okay. You still have to either find a family member or a friend to drive you for care, potentially look at staying overnight depending on how long the drive is. And then we add the complexities of the climate in this neck of the woods. So we think about in the winter, it's very challenging for many patients to get to where they need to be. We wanted to be able to offer not only cancer care, but clinical research trials as part of their cancer care in the communities where they live, or at least in closer proximity to where they were before. And part of that is really this belief that within the oncology space, clinical trials are another treatment option. So gone are the days where a clinical trial was a last-ditch resort or something that, you only did if you were in certain circumstances. This is something that we want to offer to our patients in every stage of disease, even so much as thinking about prevention or early detection, because we know that as a community, we can only move the scientific discoveries forward as fast as we move our clinical trials forward. And by offering clinical trials, many times our patients have access to treatments that they wouldn't otherwise have 2, 3, 5 years before they're available through the FDA approval. So that's really where we have wanted to look at not only expanding our sites, so where can we put additional research sites within our footprint, but how can we also be more innovative and think about using tele-oncology for clinical research enrollment, following patients while they're on study, and then potentially being able to centralize some of that research work so that in these small communities where they don't have the volume to support a full research program, they can lean on some of the larger sites and still offer those options for their patients.
So you've had to get creative for the best in care to your patients. Tell us how you got started using telemedicine to improve patient access to trials, and when you began, exactly how did it work? Did the patient come in initially and do all the consents at the big center? Were they able to do follow-up closer to their homes, that sort of thing?
So this really started probably 10 to 12 years ago, and the champion within our organization was Dr. Maria Bell. She's a gynecologic oncologist, actually the only one that we have within the system. And she really was seeing patients in multiple regions. So she's based in Sioux Falls, but she would start to see patients in Fargo, North Dakota, maybe Bismarck, North Dakota. And knowing that the best thing for her patient was a clinical trial and that they couldn't have that clinical trial as an option because they weren't, in Sioux Falls, or maybe they were 3 hours from Fargo to the north. How can we figure out a way for them to participate? And so she petitioned, at the time it was the GOG, which is a cooperative group under the federal cancer oncology program, to say, hey, can we try telemedicine? And they agreed. And we set out to work through all of the pieces to set up the billing pieces, all of the regulatory requirements. Whenever you're on a clinical trial or working with a clinical trial where you have investigational drugs, there are a lot of federal regulations that you need to work through as far as transport, inventory, and maintenance of drug. And so we had to make sure we were checking all of our boxes there. And then making sure we had the teams talking to each other. So in Sioux Falls, which has really been our hub, how do we work with the research coordinators and the physicians here and the advanced practice providers? So think of the nurse practitioners. How do we work as a team with the team in Fargo that's going to be infusing the investigational drug? Have we provided the appropriate education? Are they aware of who to call if there is an adverse reaction? Have we worked with the physician that's on call covering the infusion center in that region so that they're aware this is happening? They have the information they need to respond. They know how to get a hold of Dr. Bell. All of these very intricate pieces that you maybe don't think about right at the outset, but are really, really important, not only for patient safety, of course, number one, but when we think about data integrity and really being able to make sure that what we're providing here is good for the patient, but that we're also satisfying that other piece of let's use this as a way to progress science forward and make sure that we're capturing all of the patients who are eligible to participate.
Where are the sites and how do patients get there? Are you able to use locations that aren't in your healthcare system?
We have not used sites outside our healthcare system. Right now, we're focusing primarily within our footprint. We do have 2 sites that were added through the University of Minnesota. There was a Minnesota state legislature appropriation for funds. I want to say it was last year or the year before, that really looked at how do they expand clinical trials again to underserved populations. And so in our area of the country, a lot of times underserved populations are defined by geography. And so we applied and were awarded 2 sites. So we added a site in Worthington, Minnesota, and a site in Thief River Falls. And so we're working on building the infrastructure in those 2 sites with the on-site cancer center staff. So pharmacists, nurses, physicians to be able to offer treatment trials there. And then also thinking about, are there other sites beyond that where we can really develop additional framework, maybe in piece and parcel to either a full program or a partial program, where we provide virtual infusion services. We had a grant for a while where we did virtual infusion services, which again is another element. Maybe some of these small town hospitals have an infusion center, but they don't have anyone with experience in chemotherapy delivery. How do we work with those nurses to make sure that they have the education they need? And again, they've got someone kind of at the home base who can help them administer chemotherapy or immunotherapy as part of a clinical trial. So it's constantly just looking at what is the next thing that we can do and making sure that we're collaborating with the regulators that oversee clinical trials and helping them to understand how very important it is that we get these options out to patients where they're at and what are the barriers that we're seeing for that. How can we work together as a team of operators and regulators to really move this mission forward? And there's been some great conversation about it.
Do you have any barriers with reimbursements for the visits?
Yeah, absolutely. Again, another challenge that we really needed to work through. Medicare has specific guidelines on what you can and cannot bill as part of telemedicine. And so understanding what areas were metro areas, what areas were rural areas, and how we set up those visits so that we didn't have any trouble in billing to Medicare. And certainly there's a lot of nuances to that we probably can't get into here, but we were able to work through that and find a way that was beneficial for the patient and also followed all of the Medicare guidelines.
Talk to us about how both providers and patients have responded to using telemedicine. Is there a lack of proper education, or are both parties receptive to it as a means of their health care?
It's been interesting to watch. I think as in general, our patient population is becoming more comfortable with electronic means of communication. And knowing that you can stay close to home with your family, some of the therapies that we're prescribing now, patients can continue to work. They're not as toxic as they used to be. So having tele-oncology or teleclinical trials as an option closer to home allows you to really kind of round out that quality of life component. I think patients have really appreciated that. No longer is it, jumping in the car and spending 4 hours to drive someplace only to turn around and drive 4 hours. And as far as the physicians are concerned, I think they're equally as eager to find innovative solutions for their patients because they really believe in the work that we're doing as a clinical research department and understanding that these are treatment options for patients and that where you live shouldn't be a barrier to the treatment options that you're offered.
Are there any elements you think a smaller system could take from Sanford's model and replicate? Do you have any relationships with smaller cancer programs?
So we do try and network with other cancer programs. We're actively involved in the South Dakota Comprehensive Cancer Coalition, and actually we're able to have cancer clinical trial enrollment added to the state cancer plan. Again, many of the key stakeholders felt that it was important as a component of general cancer care. So I think really probably the takeaway for smaller cancer sites is to just continue with the innovation. Definitely lean on the sites who maybe have done it, but I think that goes both ways and that we can learn a lot of things from the smaller sites too. It's just really making sure that we're pushing things forward and that we're making connections so we understand what somebody's already done and we're not reinventing the wheel.
What are the plans for the future?
Plans for the future. Well, ideally, we would like every patient to have the opportunity to participate in a clinical trial if they choose. So what we're working on here at Sanford is building a clinical trial portfolio that covers our patients' needs, not only in terms of thinking about what can we do via tele-oncology, but do we have trials that will fit patients in different stages of disease. The other thing that I would mention about the work that we're doing and where we'd like to see this go in the future is maybe a little bit more broad than tele-oncology, but I think it fits. There's some new guidance documents that are being reviewed at a federal level and really just thinking about how do we as a science community make sure that we are pushing that envelope. So are we looking at the appropriate eligibility criteria? One of the things that we had focused on a few years ago in our footprint was other diseases that patients may have that would knock them out of the running for being part of a clinical trial. So maybe our population has a high incidence of diabetes and you can't go on trial if you have diabetes. How can we as a community think about choosing trials that fit our population? And if there are trials that don't fit our population, but we really should, how can we work with other key stakeholders on a more national level to make sure that the trials that are being designed really fit what's happening in the community setting? Because we know 85% of patients are treated in the community setting and not at academic medical centers.
Let's talk about your virtual tumor boards. How do those benefit the providers in rural areas?
Oh, I wish you could see these. These are so much fun. So the multidisciplinary tumor boards are a great way for physicians to learn from one another and really fulfill that collaborative environment. So for example, our genomic tumor board, we started that 4 or 5 years ago, and it went from a half an hour a week, and it's now an hour and a half a week split into 2 separate chunks. And what that is it's really a time for all of the physicians, both within the Sanford footprint, as well as we have one international collaborator actually that calls in to sit down and really review cases. They can stay on top of the most recent literature because the cases are presented with what's been published recently. We can talk about things with the multidisciplinary team that are applicable to this conversation. So do we need to think about, can that trial be in a different location? Can we work on a tele-oncology solution for that? Maybe we don't have a trial for this particular mutation, and how might we go about fixing that? So it really is kind of the epicenter for the cancer program to think about all things related to the care of that patient, and then really expanding it out upon how can we look at the discussion around this patient and apply it to the needs for the rest of the patients in the program.
Are you able to identify immunotherapy trials as well in these boards?
Absolutely. Yeah. So we have, let me count them up, I think eight or nine different tumor boards every week. And the way that we operate is there are 4 screens in the front of the room. And one of those screens is dedicated to clinical research. So we have a research coordinator who screens all of the patients before tumor board and then presents trial options at conference in real time as they're developing the treatment plan for the patient. And we can go through different trials, and we have everything from immunotherapy to standard chemotherapy. Again, I mentioned sometimes there's quality of life studies or cancer control studies, and those are all presented within the tumor board.
Let's talk about your tumor boards and how they've evolved into covering specific cancers and then molecular tumor boards over time.
Yeah, this has been another interesting progression to watch. So when we started multidisciplinary tumor boards, you're right. It was I think our very first one was lung. And then we started really looking at all of the different disease sites that we could offer. And then when we took our first step into precision oncology, again, it was probably about 5 years ago, we understood that we needed to have a different venue because a breast cancer isn't a breast cancer at this point. We really need to look at the molecular pieces of that. So what we've decided as an organization is that every test that is sent out for molecular testing comes to the genomic tumor board. So there's still all of the other tumor boards that meet, but if you've had molecular testing, then that's where we send that case for review. And certainly they can consult with other tumor boards if they need to. But it's really just trying to define how can we best not only use the tumor board to decide on a treatment plan for a patient, but really utilizing that space as a way to educate our providers and understand what the needs are of the patients in the program.
How do the patients respond?
I have not specifically asked a patient, but I can only assume, based on how it works, that patients feel a little bit more comfortable knowing there's a room full of people that are deciding what's best for you. And when I say a room full of people, it's a full room. There's many times there's physicians, and that could be medical oncologists, radiation oncologists, it could be nurse practitioners, pharmacy, genetics counseling, clinical research, nutrition, social services. So it really is everybody who could benefit that patient really deciding what the patient needs.
What makes the Sanford model different than tumor boards in other health systems, do you think?
There's probably many similarities. The most profound, in my opinion, is the fact that they're prospective. So as cases are coming in, we're meeting and we're identifying a treatment plan, which really allows us then to incorporate that clinical research piece and identify patients that might be eligible for trial. I think more institutions are moving that way, but certainly when you do the retrospective tumor board, you miss out on the opportunity to impact the treatment plan.
Thank you to Lora Black for taking the time to share her program's experiences. We hope you're enjoying our series on rural cancer care and that it's given you some practical and useful ideas on improving patient care wherever you are. The final episode in this 3-part series, produced in collaboration with the Montana State Oncology Society, will be released in December. If you like what you hear, make sure you hit the subscribe button on your favorite podcast app, so the newest episode will be delivered right to your mobile device as soon as it's available. Also, we'd appreciate it if you gave us a review. That's how other cancer professionals discover us, and that's how we can continue to create more content for you. Next time, we'll examine the changes to oncology pharmacy in the current healthcare environment. And we'll hear how one program centralized their authorization and denial processes into the pharmacy department, successfully overturning almost 2/3 of denials every year. Until then, for the entire CancerBuzz team, I'm Summer Johnson.
CancerBuzz is a resource of the Association of Community Cancer Centers.